Hi, this is the Cardiovascular group, and we are presenting Myocardial Infarction. And our case study is a 54-year-old agricultural farmer that presents to the ED with chest pain, unrelieved by rest. He has substernal chest pain, started this morning, radiating to the left shoulder, accompanied by nausea and vomiting, and had some diaphoresis. He smokes about a pack and a half a day, times 34 years, and has a positive family history of his mother having an MI at age 57. He has a diet high in salt. His past medical history is unknown. He hasn't seen a healthcare provider in over 20 years. His psychosocial life is basically he's been married at a young age, has 4 children that are almost grown, and he works about 7 days a week on the farm, lifting, walking, and usually 10 to 14 hours a day. He has no drug use. So on our assessment, I'm just going to run through this and you can read it, but positive things, slightly pale, upper extremities, capillary refill was sluggish. He didn't have any edema, but he didn't have hair growth below his knees bilaterally. His positive for GVD pulsation when he was supine, but not when he was elevated to 45 degrees. Carotid and brachioradial and femoral were all okay as far as pulses. His PT and DP were only 1+. And then cardiovascular wise, his inspection was pretty normal. The palpitation was a little off to the 5th and 6th intercostal space. And auscultation was also normal except for the grade 3 systolic murmur that's present at the left lower sternal border. So we're just going to take a look at a couple of the normal coronary circulation. He presents with chest pain, so this coronary circulation is very important here. And you can read each of one of these, but just the basic ones, you have your left coronary artery right here, and then which goes down to the circumflex, and then the left anterior descending, which does quite a bit of the heart. And then the right coronary artery is the main vessel also on the right side, and that goes around to the back. The blue veins are basically coronary sinus. And this is after the heart muscle has used up the oxygen. Here's another picture, and I'm basically going to talk about collateral circulation and how important that is. Collateral circulation is basically a network of tiny blood vessels, and under normal conditions it's not open. However, when the coronary arteries get occluded or the blood flow is restricted, such as in coronary artery disease, these collateral vessels can enlarge and become active. And this allows the blood to flow around the blocked artery to another area to get past that. So this picture over here to the right is showing that, where you have the blockage and you can get over to there. This picture here is another picture of the coronary artery and vein flows, and then at the top is the aorta or the ostia. Let's talk about the flow a little bit. The flow of oxygen is very demanding in the heart. It uses anywhere from 70 to 80% oxygen exchange, whereas your skeletal muscle only uses 20 to 30%. So that tells you how much oxygen is needed to get to the heart. Good perfusion, good auto-regulation with your pressures need to be adequate for your coronary arteries. And then you have the mediators and regulators that are important, and this basically is mediating when you need more blood flowed because of oxygen, such as an extreme exercise or exercise, and then when you need to reserve that oxygen. And then you have the sympathetic and parasympathetic responses that cause vasoconstriction and vasodilation during any type of processes. So the pathophysiology of myocardial infarction is basically ischemic death of cardiac tissue, and sustained ischemia leads to injury. And it's pretty simple, but there's different causes. It's atherosclerotic plaques can either obstruct or break free and have thrombus. Coronary spasms, you can have coronary artery embolisms, you can have the lack of oxygen can also, as we had talked about, how much oxygen is needed. So it's really dependent upon the coronary artery that's occluded or damaged and which part of the heart it will be on. So it could be the extent of the occlusion, the duration, the amount of tissue that's supplied by the vessel, such as the LAD, which is a good piece of the anterior piece of the heart, and then the metabolical needs of the affected tissue. And then, of course, if there's collateral circulation, that's better. And it could involve the whole encardium, myocardium, or epicardium. It could be a combination of both, or it could be all three of those. Okay, well, this is a picture of showing you what the damage could look like within a period of hours. And the first hour is going to show basically a little bit of a risk, and then the second hour shows a little bit of necrosis, if you see that zone of necrosis. And then 24 hours, the zone of necrosis is all the way from the epicardium all the way out in the myocardium. So that's just a good visual to show you how an infarct, the longer you go, the worse the damage is. Hypoxic injury is the most common cause of cellular injury in the heart muscle, and there are several factors that can cause hypoxic injury. It's oxygen in the air, of course, high altitudes. Also, a lot of people go up to the mountains and then end up having chest pain. A loss of hemoglobin or a decrease in hemoglobin can also affect, and then your disease processes, cardiovascular and respiratory. And then there are poisoning of the cytochromes in the blood, and that's basically the toxic material when the cell is dying. And let's talk about the cellular response. It's quite intense when there's ischemia. Hypoxic injury leads to cellular responses. Within 1 minute, the heart is interrupted and doesn't want to contract normally. So if you're having very difficult 3 to 5 minutes, it stops contracting, and then that's going to start the whole process of cellular response of rapid decrease in myocardial phosphorylation, a decrease in ATP, and then that's your energy. So the anaerobic metabolism begins, and that depletes your glycogen stores. The plasma membrane pumps fail, your sodium, potassium, calcium, and then that leads to swelling, the cellular swelling, and then you have accumulation of hydrogen ions and lactic acid, and that's decreasing your pH. And then the release of the catecholamines, which that releases epinephrine and norepinephrine and imbalances to the parasympathetic and sympathetic functions. So that leads to dysrhythmias and heart failure, and the elevated blood sugars for probably about 72 hours. So it's very important. You can see this diagram over here. It gives the process of all of that going on. And it's important that we get reperfused quickly. So reperfusion injury, you think that's a good thing. Its blood flow is restored. It is. However, it can be also very deadly because of the toxic substance that are getting released back into the tissues, so your oxygen-free radicals, the calcium flux, the pH changes because you have all this permeability going on. You also have the angiotensin II that's released during the MI, and that causes peripheral vasoconstriction and fluid retention. And then it also does it locally, and that instigates the catecholamine releases, and that causes coronary artery spasms. So let's talk about the pain that someone feels when they're having a heart attack. Everyone is different, and we'll talk about gender differences here in a minute, but there are sensory fibers in the heart. There's little sympathetic afferent nerves and then there's parasympathetic afferent nerves. And there's a video that's a supplemental to here. It's a very good video. It talks about how the pain works and how the whole myocardial infarction piece, the physiology on it, and it's really good. So I suggest you to use that. For more information, I can't play it because of time, but the activation of the pathway is dependent on the location of these pain receptors, which arteries are involved, and then you have the plasmakinins that are activated. And it's basically your pain is having this, it's getting this signal from the heart, but the brain is confused because it doesn't normally get pain from the heart. And that's also, those pain signals are also with your arms and your jaws. So sometimes that's why you see people that have pain in their arms and their jaw with chest pain. So let's talk about gender differences here. Women who are usually a right coronary dominance and can present with chest pain without having obstructive coronary artery disease. They can have chest pain, so don't be fooled though if they don't. They might present with shortness of breath or pressure or pain in the lower chest or upper abdomen. They could have dizziness, lightheadedness, or fainting. They can have upper back pressure or extreme fatigue. This video here, you can click on that. I'm not going to play it because I don't have time, but it is made by the American Heart Association regarding women and how they try to believe that it can't be happening to them. It's a great video. I hope you enjoy it, but I'm going to move on. So this is a picture of a necrosis of the anterior wall following MIs. Both of these pictures are. And this other one is the cross-sectional of the actual heart. And we've already talked about necrosis, how the myocytes die off, and what it looks like. So that's a picture. I don't have to go back into that again on the cell death. Okay, let's pathophysiological changes. You have myocardial stunning, which is basically the temporary loss of contractility that occurs in the injured area. And it can last for hours or days after the tissue has been reperfused. And it's basically just because of the electrolyte pump to services and the calcium homeostasis and the presence of toxic oxygen radicals that this happens. Hibernating myocardium is where the myocardial tissue exhibits abnormal contractility as a result of chronic ischemia. It means it's kind of like hibernated out, and it's adapted to the metabolical to allow for myocyte survival until the tissues can be reperfused. It's possibly reversible when the perfusion is restored if it's done in a timely manner. And then you have the myocardial remodeling, and that's just changing the size and shape and the structure of the function of the heart. The myocytes hypertrophy, and there's scarring, and there's loss of contractility in areas even distance from the site of the actual infarction. It is possible to reverse remodeling, but it depends on the time frame and how long the injury is there. Inflammatory response is first, and then there's repair of the wounded tissue, and then the body, the leukocytes infiltrate to the necrotic areas, and scavenger neutrophils are released during the prolytic enzymes that degrade the necrotic tissue. This weak collagen matrix is deposited and is very, very vulnerable to re-injury during the first 10 to 14 days. So that's very important for our farmer because he's very active, and he's going to need to understand that he is going to have to limit his activity until he's had some good rest. And this illustration just shows the changes that can particularly occur by myocardial remodeling, and the bottom left picture showing adequately healed MI with scar tissue. So the results, it's either a STEMI or a non-STEMI, and transmural or subendocardial. And you will know hopefully by your EKG some sort, because if it's a STEMI, it's usually time is of the essence and they need to get to the cath lab. And there can be full thickness injury. And there's ST elevation, which is shown here in this EKG. I don't have time to explain EKGs, but that is what a ST elevation looks like. And then there's the subendocardial infarcts, which those are usually where the patient has had some narrowing of the vessels or a thrombus has broken through. It doesn't usually affect the whole wall, but it can. I've seen it where it can. And it's called a non-ST elevation. Genetic factors associated with an MI is basically your positive family history, and which means if there is a positive family history, there needs to be some primary prevention for the siblings or the children, and in this case, our farmer did not do that. And then there's also the gene-related elevated risk factors. And here it just shows genetic variations in the genes for the LDL cholesterol. And as you can see, the PCSK is 80%, which means you'd have 80% elevated risk. And our genes are our genes, and that's what my little cartoon's about. They're expressing themselves, and we just have to protect ourselves from our genes sometimes. So that might require a little bit of change in lifestyle. So developmental risk is gender and family history. So the incidence of atherosclerotic vascular disease and MI is higher in men than women. However, women, as they get older and go through menopause, can have increased their risk because of the hormonal changes and the decline in estrogen. So just keep that in mind when you're examining women at that age. And then there's the family history. That is always a risk factor and always should be looked at as having screenings. Risk factors associated with an MI, well, it's definitely lifestyle, which is also behavioral. Smoking, obesity, sedentary lifestyle, not being active, high stress levels. And just for us students, this high graduate school, high stress levels, just saying, we could be at risk for MI. High quantities of alcohol consumption. Disease, diabetes, hypertension, obesity, dyslipidemia, hypercholesterol. Gender could be men greater than women, depending on the woman and the time of her life. And then family history is a key risk factor, and it's usually in the first degree relative. The use of oral contraceptives and older age. Behavioral risk factors, which I just mentioned, stress is pretty high up there for MIs, and then smoking and diet. Smoking's probably higher, and these are all ones that we can control and change to decrease our risk. Environmental risk can be several things, of course. There's stress again, there's that stress. Air pollutants, such as ozone and pesticides, which our farmer is exposed to. Secondhand smoke is a risk factor. Chronic noise exposure, and traffic. Driving in traffic is a big risk exposure. So let's summarize our patient. Mr. MV, he was given aspirin upon arrival, and troponin and CK-MB and EKG were positive for STEMI MI. He was sent directly to the cardiac cath for a stent placement to his LAD. Now, associated risk factors were basically he had not been to a physician over 20 years. He had been smoking for over 30 years. He has a family history of an MI. His environment, his behavioral with diet and his stress for working long hours have all contributed to his event. So our assessment was primary STEMI MI. Secondary is arteriosclerosis and peripheral vascular disease. And the reason is for that because he had his pulses in his feet were not as strong, and he didn't have hair growth below his knees. And then our plan is he's going to need an extensive cardiac workup because we don't know how extensive this cardiovascular disease. Maybe some diagnostic carotid peripheral ultrasounds to look for blockages, and then definitely we'll need cardiac rehab. Health promotion, he's going to need to understand about annual primary care visits, heart healthy diet, smoking, to stop smoking. His education will need to be nutrition, smoking, stress, and then he's going to be on new medications. He's going to be on like Plavix, and he's going to be on metoprolol, and he's going to be on an ACE inhibitor. And then education about making sure that he follows up with his physicians. That's going to be key with this patient because, as you can see, he's not been going to the physician. And so that's going to be a number one probably risk factor for him, that he doesn't return upon his visits. So I hope you enjoyed this, and we'll talk to you next time.